All right, so we're doing the immune system for this section here. Any questions from the cardio stuff we covered before? So you're covering some similar stuff in anatomy, cardiac physiology, or at least the anatomy. Does everything line up kind of between the two classes, hopefully? All your lubs and dubs are in order? Okay, okay, fantastic. I did the test, updated that. I think I had some good questions in there, some things you have to kind of think through. Try to put in, a few more sort of like patient scenarios. So, kind of going through, okay, a patient has this happen, or say, for instance, they're dehydrated, or say, for instance, they drink a whole, 3 liters of fluids. What changes might you expect to occur down the line? And so, again, kind of understanding the different changes in hormones that are being secreted, whether it's atrial natriuretic peptide, whether it's renin or angiotensin 2 or anything like that. Having a good understanding what's occurring when those changes happen and what kind of the downstream effects are going to be. Okay, so have a good understanding of that, and then we'll do some questions that are similar to that on the reviews. You have a better idea what I'm talking about. Okay. All right. So we're going to talk about the immune system here. We're talking about both our innate and immune systems, kind of the differences between those two, and all of that. So anyway, so we have defense mechanisms. What are some examples of defense mechanisms that kind of try to protect us from the outside world? The skin's a good one, right? Kind of like our natural armor, so to speak. Anything else? Stomach acid is a really good one. Yeah, we actually run into issues when you have, because normally, stomach acid, we mentioned like a pH of 2, right? It's not really compatible with a whole lot of bacteria life. Bacteria don't like to live there. There's actually one particular type. If you guys ever heard of H. pylori? A lot of peptic ulcers. That's one that actually can kind of protect itself from the stomach acid. But actually, one of the things we run into when you have patients who we are trying to, we have like critically ill patients, and one of the things we were talking about is that when you have, like, say your cortisol levels are climbing because you're critically ill, right? So again, you're in a really, really stressed state. You mentioned that has some negative effects on the GI tract. It actually decreases that protective mucosal barrier in the stomach, and so they have a risk for developing like peptic ulcers. That stomach acid basically eating through the GI tract. And so one of the things we do to protect them, we actually give them medications to help prevent that acidity, prevent the acid from being produced there. But one of the downsides of that, and again, it's always a double-edged sword with some of this stuff, is when you have less of that stomach acid, what do you think can happen now to bacteria in the GI tract? They can start to grow, right? They can start to replicate in the stomach, and then you can have certain bacteria that will then, kind of eventually translocate themselves and get into the respiratory tract, and that can cause a pneumonia, right? So again, these are all going to be things where it's good to understand kind of the baseline defense mechanisms, and then if you're modifying those, what are your potential risks? What are potential things that can happen as a result of these changes? That's just one example. We'll go over some more as we go forward here in just a little bit. So we'll talk a lot about our cell-mediated immunity. Specifically, remember, which cells are we talking about mainly here when you're looking at this kind of, you're starting with these pluripotent kind of progenitor cells. Which ones are we really referring to here? The white blood cells, good. So again, we're going to be mainly looking basically through here, essentially, right? We're going to find that our mast cells are also going to be very important as well. I guess I should have maybe done one of these. We're going to find this is also important for protection, for allergy, for immunity, things like that. But these are the main cells we're talking about. So remember, we have our granulocytes and our agranulocytes. Which one are the other granulocytes? Basophils, eosinophils, and neutrophils. I always think never eat bananas, right? Because remember, never eat, little monkeys never eat bananas, even though they really do. But that's how I remember. So never eat bananas is your granulocytes, and then you have your agranulocytes would be what? Yeah, lymphocytes and monocytes. Yeah, so those are the big differences there. And again, what is something that like our eosinophils are good at helping us with? Parasitic infections. Good. How about like the neutrophils? Bacteria. Anything else? Viruses is another good one. How about what's our basophils helping us with? Yeah, it's going to be a lot of histamine, a lot of allergic responses are going to be mediated through the basophils. Good, yeah. So having kind of a good idea of what these individual cells are doing is going to be helpful for moving on and talking about how we actually, develop this immunity, how we have protection against, foreign invaders, essentially, right? Now, does this process, these cells always work as intended? Are there cases where maybe they can start like attacking things that they shouldn't be? What do you call that? Those are autoimmune disease. We'll talk about some examples of that when you have the immune system kind of running rampant on our own cells versus working on, say, foreign invaders potentially. When I say foreign invaders, I'm not talking about like you know, the Huns or something like coming over, like bacteria, pathogens, you know, things like that, right? Anyway, so when you're looking at the cells, you can kind of, especially when you're looking at the lymphocytes, the two main delineations here we're going to talk about are going to be our T cells and our B cells. Where do the B cells come from? Come from the bone marrow, right? So again, you're going to find that we'll have sort of these kind of common progenitor sort of cells, kind of common ancestral origins essentially. But as they break down, you're going to find that they will start off kind of these premature cells will start off in the bone marrow. The B cells will then develop in the bone itself. So B cells in the bone. How about the T cells? Where are they going to? They're going to be going to the thymus. So you'll have kind of immature cells moving over to the thymus. That's when they can then develop themselves, and that's when you're going to develop our T lymphocytes. What are the purposes of these cells here?
Are they like phagocytic T lymphocytes and then plasma cells or antibody antigen?
Yeah. So we'll look at the B cells are going to be really important for talking about antigens and antibody production, specifically the T cells. Not so much as being phagocytic as more as helping to release a lot of like inflammatory cytokines. We'll talk about those. It's going to be helpful for helping to identify cells that are we want to attack essentially, and helping to kind of moderate the process and make sure we're getting other cells involved in order to fight off an infection potentially, right? So we'll talk about all these details here, but this is kind of where we're going, at least with the lymphocyte aspect here. Okay, so we'll talk about two main types of defense mechanisms that we have. So we have things like innate, non-specific sort of immunity. These are things that typically are inherited versus an adaptive or specific sort of immunity. This is going to be kind of a learned response to that, right? So if you imagine if you were to say like get a vaccine and now you're immune to a particular type of virus, what would you call that? That'd be more of an adaptive thing. Or if I were to get an infection with a bacteria and then I develop immunity against that, would be more of an adaptive sort of thing, right? So we'll talk about the different types here and what can kind of be considered each one. We're going to see that, you know, normal cells that can function on their own without having any sort of, you know, prior immunity needed, you know, things like, you know, your phagocytes, things like your natural killer cells, like these are going to be, you know, kind of big functions of the innate immunity, whereas a lot of like our lymphocytes and things like that are going to be part of that more adaptive or specific immunity, as we'll find. So certainly have sort of external and internal variety. So we mentioned the skin being a big one. You know, even within the skin, we have lysozymes that can digest bacteria and kill them off. We talked about the digestive tract. Now, again, external just meaning like not actually internal to the body itself. So if you think of humans, we're kind of just one big tube if you kind of think about it, with the GI tract kind of being the inside of that tube. I know it's a little weird to think about yourself like that, but the digestive tract is still considered sort of external in this case here, right? And so typically we mentioned, you know, you can have a lot of acidity within the stomach that can help to eliminate that. How about like within the rest of the GI tract? Like, you know, are we devoid of all bacteria? No, we have quite a lot of bacteria, right? What do you call that? No, yeah, we have like a normal flora, right? And however, you can modify that. You can do things to disrupt that sort of defense. For instance, if we were to take, say, antibiotics, and that can potentially disrupt that flora. And then anyone know what type of infection you can get secondary to that? Yeah, anyone you've heard of C. diff before? How's that usually manifest? Diarrhea. Diarrhea is one of the big things. Has anyone ever smelled C. diff diarrhea? Once you smell it, you know what it is, and you can smell it in the ICU from like a mile away, essentially. But once you And so that is a thing where you're actually disrupting the normal flora of the GI tract, and now you have an opportunistic sort of infection. You have this Clostridium difficile coming in and developing an infection there. So that can be a really big deal for patients receiving antibiotics. But again, us disrupting kind of the normal defense mechanisms. The other big things would be the respiratory tract. We have things like alveolar macrophages, which are going to be good for as phagocytic cells. You're also going to find that what other sort of defenses do we have in the lungs? Because again, the respiratory tract, especially when you get really deep down in there, you're going to find it's usually a pretty sterile environment, which is good, because if you get an infection in the lungs, what do you call that? It's a pneumonia, right? So you want pneumonia. So how do we keep the respiratory tract pretty clean? The cilia, we have ciliated cells along the respiratory tract. They're going to help to move gunk and mucus and things like that, things that we've tracked these particles in, move it up, and then you can eventually swallow it or cough it up or whatever it happens to be, right? Imagine if you had someone who's chronically damaging those ciliated cells. Who might be doing that? Yeah, smoker. So whenever you're inhaling these really hot, sort of acrid gases, you can damage those cells over time. They can either become like paralyzed, or you can just damage the cells to a point where they will undergo this kind of sort of dysplasia, almost like building a callus up on your fingers when you're aggravating that skin. Kind of the same thing happens where you lose those ciliated cells, and now they can't transport that stuff up. So one of the things you'll find is patients who have chronic smokers, if they have COPD or they have emphysema, things like that, you're going to find very frequently they're going to be developing pneumonias, respiratory infections, either viruses or bacteria, and they're very frequently coming to the hospital for care for that. So it's one of those big things. So anytime you're disrupting the normal defense, expect that you're going to have more infections as a result of that. Internally, we're going to see things like our phagocytic cells, very good for destroying bacterias. Some of them are going to be good for destroying toxins, viruses. We're finding that we'll have different cells and different tissue types that are going to be a little bit more specialized depending on where they're at. We're going to have things like interferons. Interferons are going to be good for maybe protecting cells that haven't been infected by a virus. We can actually see interferons are going to be useful in certain types of cancer treatment. We can see this is important for certain viral applications. We'll talk about that a little bit later when we get into those specifics. Well, things like natural killer cells, which are going to be good to destroy cells that may have already been infected with the virus. Be useful. And then mention mast cells, which are good for releasing things like histamine and other mediators of inflammation. So whenever I say inflammatory cytokines, that's what I'm talking about. These mediators that get released that help to progress the inflammation and also help to get other kind of helper cells kind of located to that area, right? So if you have an area of inflammation, it's going to try to recruit other cells to come in and kind of help out with the process essentially, right? Okay, so I mentioned the skin, digestive tract, a lot of good stuff. Even the GU tract, having a urine that is more acidic tends to inhibit bacterial growth. Looking at vaginal secretions tend to be a little bit more acidic as well. That can help to inhibit bacteria. And if you think about who's more prone to UTIs, men or women? Women. Why is that? Yeah, you usually have a shorter GU tract, and so because of that, it has an easier time for bacteria to translocate. Well, that's a different sort of defense, and that can help you to say, okay, well, I have a female patient complaining of lower abdominal pain. You can think, okay, well, I know UTIs are more specific because I know their defense mechanisms essentially are going to be different than a male patient might be. So little things you kind of take into account based on these differences. Internal, we mentioned phagocytic cells, so we'll talk more about these in a little bit later. But again, when I say phagocytic, that just means what? They're going to Pac-Man up the bacteria and whatnot, right? We'll also talk about things like complement proteins. Anyone know what these are good for? Tell you how nice you look today, right? So, go ahead. What do they do? Yeah, they can sort of help with like self versus foreign. But one of the big things they do. Anyone know heard of the term opsonization? What does that mean? Makes them more tasty, essentially, like to the phagocytic cells. That's how I kind of think about it. So opsonization makes them more attracted to phagocytic cells to come in. They can also be useful for helping to lyse the cells directly. So we'll talk more about those in detail later on. Things like endogenous pyrogens, these are going to be things like leukocytes that are producing, that can help to destroy the cells. We talked about natural killer cells and mast cells. So again, we're going to go into more detail on these. We'll primarily be looking more at the internal sort of defenses here. However, it seems like you guys have a pretty good understanding of the external ones. And when we get into specific organ systems like the GI tract, et cetera, we'll talk more about those in detail as we get there, right? Okay, so three main types of phagocytic cells we'll be dealing with. We have things like the neutrophils. These are typically, and again, when you're looking at like a CBC with differential, what's normally going to be in the highest proportion? Usually your neutrophils are going to be the highest proportion of your white blood cells there, and so those are going to be mainly circulating within the bloodstream. You're going to find these are much more likely to show up first when you have a site of inflammation, right? Now, certainly tissues can have things like macrophages that are already present, but again, when you're having kind of newcomers coming to the fray, essentially, you're going to find the neutrophils are kind of the first ones to show up. The monocytes, they're circulating in the blood, are also going to be showing up a little bit after the neutrophils. And again, once the monocytes partition into the tissue, what do they turn into? Yeah, so we're going to see them turn into macrophages. I'll show you what that looks like in a little bit. And then I mentioned you're going to find that the tissues may already have some macrophages associated with them already, so particularly like in the liver, the spleen. We'll talk about the specific instances in just a few minutes here. Okay, so I mentioned neutrophils typically found all throughout the body. Find a lot of them located in the blood, find them a lot in the tissues as well. The monocytes, however, are going to be the ones that are going to be circulating in the bloodstream before they turn into macrophages, essentially. And we know the term when you have like an immune cell crossing, say, from the bloodstream out into the tissues. So chemotaxis is the process of like kind of those inflammatory cytokines I mentioned, kind of drawing those cells to the area. What do you call it when you actually have them crossing through the endothelial lining there? We're going to find a term called diapedesis is what that's called. So basically the cell can kind of slip through the endothelial lining to go from the bloodstream out into the tissue, right? So that's important because if they can't get through, then And we'll talk about why inflammation is going to make that process a little bit easier when we get into some of the inflammation steps. Anyway, you're also going to have tissue macrophages. You know, you can especially find these like in the spleen. The spleen is really good for filtering what? Yeah, we're going to find the blood is going to be the main thing. The spleen is going to be filtering here, but also like in the lymph nodes, which is very good for filtering tissues or fluid from other tissues, essentially. And then more specifically, we have things like, you know, these Kupffer cells, which are going to be found within the liver. We also have alveolar macrophages. We'll talk about the alveoli in the next section coming up. And then also you have, you know, specialized central nervous system cells like the microglia. Again, the CNS is already a very well protected area anyway, because we had that blood-brain barrier that normally keeps most things out. However, we also have these macrophages that are good for helping anything that gets across. Because again, if you get an infection in the CNS, what do you call that usually? Usually it's a meningitis, yeah, that develops there. Certainly you can have other sites that specifically get inflamed, but that can be a big thing. And so, especially when you talk about pharm, you know, when you have a meningitis, you know, you want drugs to get to the site of infection, but if that blood-brain barrier usually is pretty tight-lipped for the most part, doesn't like things to cross over, you have to find the right antibiotics to make sure they can actually cross over. So if I'm using a molecule that's too large, it's never going to get across, right? It may actually influence which drug I'm going to use versus another one. So again, think about the site of infection is going to be really important as well, and what sort of defense mechanisms are already there. Just some examples showing you some of these different phagocytic cells. You can see here like the alveolar macrophages. For instance, you can see some of the kind of the neuroglia they're going to be helping out with the defense within the CNS. And then here's a slide of a liver slide, and then you can see these Kupffer cells that are going to be useful for digesting products that are going to be within the liver, which is good too, because again, a lot of the blood flow coming from the GI tract normally ends up in where? It's going to be hitting the liver, right? So it's going to be one of the primary places where you're going to see a lot of filtration occurring initially, and so it's good to have some macrophages that can hit any tissues there, or hit any, you know, kind of foreign pathogens there. Yes, sir.
Do those Kupffer cells have anything to do with like detoxification or peroxisomes?
They're a little different. You might find that the peroxisome, like those Kupffer cells will probably have peroxisomes located within them, right, to help to kind of digest stuff, right? But you're also going to find that the actual hepatocytes themselves are going to be primarily, we see like a lot of like metabolism of toxins and things like that. Yeah, so a little bit different. Okay. Other sorts of innate immunity we have things like the interferons. Typically, you can find interferons being useful as sort of an antiviral sort of product, good at fighting viruses off. We have three main types we're going to run into. You have things like alpha and beta. These are typically going to be inhibiting things like viral replication and assembly, especially when you're talking about viruses that get into the cell, and that's where they usually have a lot of their replication. These interferons can help to kind of prevent that. And again, I'm not going to have you memorize like all these slides here and okay, this one interacts with this cell that causes this to be released, got interact with this cell. We'll talk about some specific examples, but again, we're kind of shooting for broad strokes here for the most part, right? So just know the interferons are good as an antiviral sort of particle. You can find that the gamma interferons are also going to be good for certain cancerous cells, and you can find that with certain cancers, you're going to find they will have mutations that cause them to be a little bit more present, more kind of, you know, the interferons can be kind of more aware of them because they may be expressing a certain receptor or something. And so gamma interferons can be very good for helping out with that. So for instance, we have some of our I don't remember which specific indications. We have a couple of kids who are getting certain cancer regimens. They're getting a form of interferon that we have engineered, basically. We develop a bacteria that can actually produce the interferon for us, and we isolate that, and then we can give it to the patient to help fight off their cancer. Or in some cases, if you have things like hepatitis, especially like hepatitis C, we may use interferons as well in order to help manage that. Because again, usually in these cases, the patient is not producing enough of their own to fight off the infection or the cancer, so we can actually give them exogenous forms of it to try to help kind of bolster their immune system, so to speak. Yes, ma'am.
Is that what they call like immunotherapy, like Keytruda? Like
that, yeah, that would be an example of immunotherapy because we're trying to help to kind of stimulate the host immune system to kind of fight off the infection. Because again, the interferon itself may not actually be destroying the cancer cell, but it helps to stimulate other cells that can help to destroy those cells. As we'll see, like things like natural killer cells and things like that get stimulated by things like interferon. So we'll see that's going to be really important for that. Yep. And then, as I mentioned, you know, a lot of newer antiviral drugs, maybe targeting like interferons. Again, we'll talk about those later in pharm specifically. Just know this can be useful from that standpoint. So like cancers and viruses are a good place where interferons can help us. All right, so we're going to spend a lot more time talking about adaptive immunity, though. When we mention adaptive immunity, it just means what? Yeah, it's a learned sort of response, right? It's not something that we were just naturally born with. Like everyone's born with neutrophils, If you're not, you're probably going to be in big trouble, right? Everyone's born with things like natural killer cells with usually a functioning GI tract. These are all things that you come with, right? So that's kind of that innate immunity. The adaptive immunity are things we need to kind of develop on our own, usually in response to these different pathogens. So again, this is an acquired ability to defend against specific pathogens, and again, this is very, very specific, right? Which is why you find that, can you just get one flu shot and then you're done for the rest of your life? No, why do you have to get more than one flu shot? Because you get immunity to a couple of strains of flu, but then the next year, guess what? Now the flu is different. Now you have different strains that are going to be more likely to be present, and so now you need to have a reformulated vaccine, and now you get vaccinated against those, right? Does anyone know how many strains of flu you actually get vaccinated against now? It used to be 3, used to be most common. Nowadays it's actually 4. Actually, I remember when the swine flu was a big deal. Most of you guys are probably pretty little, but I remember when it was like, I was on rotations. I was in pharmacy school and I was on rotations, and that's when actually the swine flu that year became a really big deal. They actually included an additional strain of flu after that in order to account for strains of that swine flu. But yeah, those change all the time. So again, this is usually a very specific response. You're very specific. And if you have mutations of the virus, or if you have mutations and things like that, you're going to find that you lose that immunity. So for instance, like, do we have a vaccine against HIV? No, because why? Anyone know why not? Because you make more money off treating it with drugs. No, I'm just kidding. Because it's a very sloppy virus. It mutates all the time. So even though you could develop an immunity against one particular strain, as soon as it mutates, you'd lose it essentially, right? So that's one of the big reasons why we don't have a vaccine for that sort of thing yet. And again, it all just depends on the pathogen, depends on how much of those mutations they have, what we're specifically targeting on those things. So we'll go into more details on that. But again, this is mainly going to be mediated through antigens and the antibodies, right? So the antigens, how would you describe that? It's foreign, it's protein. That's what's generating the immune response. Antigen is generating the immune response. The antibody, though, it's going to be binding to the antigen essentially. In some cases, it neutralizes it. In some cases, it may just make it more appealing for other sort of immune cells to come in and sort of attack it, right? And again, anyone know what the general sort of form of an antibody is? Yeah, it looks like a Y essentially, right? So again, you have, and again, I'm probably not going to be completely accurate here, but basically you have different protein chains here. This is called the FAB portions, and then you have an FC portion here as well. So it kind of looks like a Y, and you have these disulfide bonds that are kind of binding them together. But this is kind of the this is the business end of the antibody essentially, right? This is what's actually going to be binding to the antigen. This is just useful for helping out with interactions with other immune cells essentially, right? So we'll go into more details on these, but this is generally what you're going to find with the antibody. Typically have a Y sort of shape there, okay? All right, so we're going to find that what produces the majority of our antibodies? Yeah, we're going to find B lymphocytes are going to be the main thing that are going to be generating that. So again, B lymphocytes are coming primarily from the bone marrow, so again, they get that B there. You're going to find these are really good for bacterial and viral infections. And again, it's very specific to specific types of bacteria and viruses. And again, they're going to be mainly secreting antibodies into the bloodstream, but also into the lymph tissue as well. Because we're going to find that a lot of filtrate, from different organs and tissues comes up through the lymph system, and that's where you can have, if you have a lot of antibodies there, they can neutralize things as they come through the lymph drain. They typically have a pretty short lifespan as well. But however, when you think about immunity, how long does immunity potentially last? Could last a lifetime in some cases, right? You're going to find that depending on, the type of infection, depending on, the type of immunity it is, you're going to find that it can range in time frame, right? In some cases, you may find you have lifelong immunity to certain things. In some cases, you may find that you need to have maybe like a reintroduction of the pathogen to get sort of a booster effect. Anyone ever had like a Tdap booster or a tetanus booster? That's essentially what we're doing, kind of re-challenging the immune system to try to make sure that you have a very durable response. When I say immunity, I'm talking about durability. That's how long that immunity is going to last, essentially, right? So something that's lifelong has a very good durability. Some things you may have to get reintroduced to the pathogen every once in a while. That's going to be something that has a shorter sort of durability or lesser durability. Okay. This is also called a humoral immunity or an antibody mediated immunity, because this is what's going to be setting off basically the whole cascade of the inflammation here is going to be due to these antibodies binding up to an antigen, and that's going to kind of trigger off everything else that happens here. Okay. And we're going to talk about 2 main types of B cells. Basically, you're going to have our plasma cells. And we know what those do. Yeah, those are going to be the main things. We're releasing a ton of antibodies, and we're also going to have our memory B cells. Those are going to be the things that stick around for a lot longer. They're going to help us retain that immunity for periods of years to a lifetime potentially, right? So again, those would be the big ones we're going to talk about. All right, and again, looking at say like a developing B cell within the bone marrow. If you notice here, you may have different sort of receptors here, and again, these receptors are basically antibodies, right? These are antibodies that are going to be binding up to antigens. And you can notice here that they all have a very specific conformation. They're very, very specific to binding to certain things. So something that binds to, say, streptococcus is not going to bind to, say, for instance, the flu. Okay, it's very, very specific in these antibodies here. And once you get challenged, once an antigen comes along and binds to it, notice here that because this antigen happened to be circular and binding up to this circular sort of antibody here, this is what got selected out. And so then you're going to find that you'll have both plasma bodies that are produced that are going to be able to release a ton of different antibodies there, and then you'll also have these memory cells that will allow us to have sort of a even stronger response if that pathogen or that antigen ever shows up again, right? And so again, we'll talk about a primary versus a secondary response to these pathogens here, and normally these secondary responses tend to be a lot stronger because again we've already kind of developed these memory cells and whatnot, and they're a lot more primed. You've kind of primed the system to be able to interact with those antigens, right? So for instance, when you have to get for all vaccines, do you only have to get one dose of it? Sometimes you need kind of repeated doses because that helps to prime the system a little bit, to help you by re-challenging the system. Maybe you get a vaccine at, say, month 0, month 2, and then month 6. By doing that, you're helping to prime the system and get it more ready to fight off that pathogen should it ever show up kind of on its own, right? And again, because I'm a pharmacist, I talk a lot about vaccines in this case because, again, that's the one way we can actually impart immunity onto somebody. As far as from an adaptive sort of response, I'll kind of use that as my example in quite a few cases, but we'll go into more details on those a little bit later. So anyway, we're looking at the T cells, though. What are T cells good for? They're going to be useful for helping to identify some of these cells that are going to be considered to be antigenic. They're going to be considered to be foreign. They're going to be able to recruit, do that chemotaxis and help to recruit a lot of other cells to the site. They're going to be able to kind of propagate this inflammation that actually happens here, and they can actually have direct sort of cytotoxic effects as well, as we'll see here in a little bit. So anyway, so T lymphocytes are going to be attacking potentially, say, host cells that have been infected with, say, like a virus or fungus or something like that. Transplanted human cells. Now, is this normally a good thing? No, we're going to find this usually sort of, it's an appropriate response because the body's detecting foreign cells. However, it's not something we want the body to do, right? So if I say we're to transplant a whole new liver into a patient, I probably want them to keep that liver functioning, right? So I don't want the body to attack it. So transplant medicine is really, really important because a lot of the meds we use are used to prevent the immune system from attacking those cells, right? But guess what? Do we have drugs that are very specific for just, okay, I'm going to prevent you from attacking the liver, but then attack everything else? Not really, right? So you're going to find that you use a lot of immunodepressants. You're going to be using a lot of things that are inhibiting the immune system. Those patients tend to be much more likely to develop what? Infections, yeah. So for instance, I remember the sickest patient I think I ever saw was this little girl who was, she had a type of leukemia, and they were going to do a bone marrow transplant essentially, where basically they wiped out all of her bone marrow. They're going to be implanting basically these other cells, and so while waiting for that the bone marrow to kind of establish itself, like we had to keep her on all these immunosuppressant sort of drugs, all these things like steroids and other drugs to try to prevent the immune system from fighting off those foreign cells. And so then she ended up developing really severe infections. She ended up getting a bacterial infection. She got viruses. So then we're having to give her antibiotics to fight off the bacterial infections, but then she ends up getting C. diff because we interrupted the GI flora, and then she ended up having a really nasty infection from that. And so you can see how these things tend to snowball when you're trying to monkey around with the host immune system. So it's very, very important. Anytime you're dealing with an immunosuppressed patient, you want to be very careful with them because, again, even a small minor infection, something that we would be able to fight off normally, they can completely decimate them, right? So again, you don't get a normal normal healthy individuals don't get a lot of fungal infections. These patients do. Things like bacteria in the soil that normally we can fight off, they can't because they're so immunosuppressed. So I'll harp on that quite a bit, especially like in pharma when we talk about drugs that are immunosuppressive, because again, that can be the thing that kills the patient essentially, right? Okay. So again, T lymphocytes themselves are not producing antibodies. However, they are working with the antibodies produced in the B lymphocytes, right? And then this is going to be considered our cell-mediated immunity, right? The humoral immunity or that antibody-mediated immunity is going to be the B cells. This is going to be our more cell-mediated immunity because these cells are directly interacting with whatever has the antigen on it to either kick off inflammation or kill the cell or whatever happens to be, right? And you're going to be finding a lot of these are going to be kind of hanging out in the lymph tissue as well. Some of these can be circulating to the lymph tissue. It's going to be a big place where you have a lot of that, again, that filtrate coming from the organs and tissues is kind of being sent up through there. So it's good to have your immune cells there as well. Okay, so just to have a little bit of comparison between your B cells and your T cells, basically where they're being processed. So again, B lymphocytes, you just think the bone, that makes sense. T lymphocytes, think the thymus. As far as the immunity goes, B lymphocytes are going to be the humoral immunity because they're releasing antibodies versus cell-mediated, and we'll go into the specifics on the T lymphocytes in a little bit later to see how that actually works. Remember, with the B lymphocytes, you're going to have your memory cells and your plasma cells. It's a very important distinction there versus having cytotoxic cells or helper cells. We're going to look at those in a few minutes here. Look at the presence of surface antibodies. We're going to see these are very important because this is what actually will help to trigger off the B lymphocytes, especially those memory cells to release a bunch of new antibodies. We'll also find that they have specific receptors for antigens. In the case of the B lymphocytes, you're going to find these are actually the antibodies themselves are going to be on the surface there. That's what's interacting with the antigens. However, for the T cells, you're going to actually find that they're going to have receptors that are present, but they're going to be related more to things like immune globulins. They're going to be interacting with the antigens specifically, right? So again, there's a little bit of difference there between those two. T lymphocytes usually sticking around for longer. Typically going to find more of these in the blood and the lymph tissue, and then you're going to find a much higher proportion of these T lymphocytes going to be located, at baseline. You're going to find that you're usually in a higher proportion there. Let's see. As far as secretory products here, this is important. So again, when you have things like your plasma cells, B cells are going to be releasing antibodies specifically. Again, it goes back to the humoral immunity versus things like activated lymphokines are going to be released here. I say lymphokines. Anyone know what that means? Basically, it's cytokines that are inflammatory. They're coming specifically from the lymphocytes. Okay, so it just means these are going to be things that are going to help to increase the inflammation process. They're going to be things that are going to help to activate other cells, things like B cells and whatnot, to help kind of get the fight, try to pick up the fight to fight off whatever pathogens there. You're going to find that the B lymphocytes can be good for certain types of viruses, but not for all viruses. Usually the T lymphocytes can be better for that. And then a lot of bacterial immunities are going to be coming from the B lymphocytes themselves. Some things you can find T lymphocytes are good for things like leprosy or tuberculosis, but these aren't common things you're going to run into so frequently. However, we're going to look at one particular disease state that actually eliminates a big proportion of your T cells, and that's going to become important. We're talking about other kind of secondary infections they can get. Okay, so those are the main differences there. We'll talk about these more in detail, so you can kind of refer back to this chart and kind of know the differences and kind of know those for testing purposes for sure. Okay, so moving specifically into the lymphoid organs. Let's say lymphoid organs, what am I referring to? Yeah, lymph nodes are going to be included with that. Anything else? Spleen's a good one. Yeah, this will be good for filtering the blood essentially. The bone marrow, I'd also probably consider the bone marrow as well, because again, that's where I have our B lymphocytes actually being generated there. So the thymus is going to be included along with this. Spleen's good, lymph nodes. These are all being places where a lot of your T cells are going to be being processed, especially the T cells in the thymus there. But they're all being derived from the bone marrow. So anytime you're wiping out the bone marrow, either due to something like radiation or chemotherapy, guess what? You're also going to be wiping out a lot of your white cells from being produced in the first place as well, which is why many cancer patients are also going to be immunosuppressed, because you're giving them treatment that's going to be wiping out their ability to produce new white blood cells. Okay. Because again, do you think these are cells that are rapidly dividing or they're pretty slowly dividing? The white blood cells. These are pretty quickly dividing, right? In comparison to other cells, like your nerves. Like the nerves don't really divide that frequently, right? Versus your white cells, they do divide very frequently. They're usually in constant state of mitosis in a lot of cases. And so this is why this is one of the first things that actually gets hit when you have something like, radiation therapy or something like chemotherapy. Anyone know any other rapidly dividing cells? Probably mentioned these before. The GI tract's a big one, right? So you can see mucosal tissue starts to break down. They get something called stomatitis, where they have ulcers and things like that make it very difficult to eat and drink. What else? Yeah, so the hair is the other big thing you're going to find. So again, alopecia is a very frequent finding for a lot of cancer patients as well, because these treatments are hitting these rapidly dividing cells. The nails can be affected as well. So again, just kind of think about those sorts of cells as being ones that are rapidly dividing. The white blood cells are another really important set of rapidly dividing cells that can be affected by different sorts of treatment. Okay. There's some other kind of secondary lymph organs, so especially places like the tonsils, Peyer's patches, which are located in the intestine. Again, the main thing they're doing here, they're trying to capture and kind of sequester these different bacteria and other sort of pathogens, and then present them to the macrophages, which macrophages do what? Chomp up the whatever happens, whatever pathogen is, or viral, bacterial. They're also going to house a lot of those lymphocytes. So again, this is where you can be starting to kick off the immune system in these sort of lymphoid organs here. I mentioned spleen's good for filtering the blood for pathogens, and then usually the other lymph organs are good for other filtrate from other organs and tissues and whatnot. So for instance, when you have someone who has, say, something like sickle cell disease, mention what was the problem with sickle cell patients? Remember, they had the mutation in the hemoglobin, right? They're substituting that amino acid. What happens then? thinking a low oxygen situation, and then what happens to the red blood cells? They start, so the proteins start to agglutinate, and then you're going to find that they get that sort of sickle shape. Remember what that did to flow of the blood? It inhibited it in those cases. So what you actually find is the spleen becomes functionally not very useful for those sickle cell patients. And so since the spleen is not able to filter the blood effectively, what do you think that predisposes those sickle cell patients to? Infection. Those pathogens that were in the blood, they could be potentially filtered out by the spleen. Don't ever get affected, right? So again, it's one of those things where infection could be a potential risk for a sickle cell patient due to the fact their spleens, they have what we call functional asplenia, or where the spleen is not really working effectively. Or if you had someone who had the spleen taken out, say for instance they had a trauma, they were in a car accident and they had to have their spleen removed or something like that due to injury, that is another patient who would also be very prone to certain types of infection, right? Okay. You can see how, these blood capillaries, they're not completely impermeable. You're going to be able to find that cells can kind of move back and forth between either the lymphatic capillaries to the bloodstream as well. Again, that process called diapedesis, when you have cells actually cross that endothelial lining, it's an important process to occur. And normally when you think of inflammation, do you normally think these gaps here between these endothelial cells, do you think they get bigger or smaller? Because you think about like an inflamed, let's say, imagine you got stung by a bee. Right, so again, that's something that's going to kick off the inflammatory cascade. What does that area look like? It gets swollen. So you're seeing that more fluid is building up. It's called edema, right? That's having tissue or water flowing out of the capillaries, right? So again, what do you think about the capillaries at that point? They're leakier, right? So they get very leaky. That's usually due to the effects of things like histamine and other inflammatory mediators. That's why that's good, is because by increasing the size of those gaps, you can have inflammatory cells that can actually cross much more easily by increasing the size of the gaps. So whenever I talk about leaky capillaries, that's what I'm referring to. And usually inflammation is one of the big things that make those capillaries more leaky, that allow for things to cross over more easily. Kind of make sense? Okay. And here, you see how the lymphatic system looks here. Normally when you think of like, an infection, and you think about like a red streak, like maybe moving up the arm or moving up the leg, that's usually the lymph drainage, what you're seeing there. And you're just seeing that line of inflammation traveling along. But again, a lot of B cells, a lot of T cells are located here, and they can, macrophages and other sort of cells that can, once they're presented with the pathogen, they can attack it directly, essentially. Okay, so talking about local inflammation. Specifically, what kind of happens when we have an inflammatory sort of injury, or we have, like, say for instance, you have something like bee sting or whatever it happens to be. Usually you're going to find a pretty similar processes occurring here that will allow for the inflammatory cascade to occur. So normally, say for instance, you were to have a bacteria that enters into the break in the skin. Okay, so say you have some sort of injury on the skin, you have bacteria starting to translocate here, right? Well, the first thing you're going to find is you're going to have things like macrophages are going to be located within the tissue, right? Because remember, when they're in the bloodstream, what do you call them? Yeah, so monocytes at that point. But again, all the tissues, you're going to have some degree of macrophages that can then kind of move themselves over to start to deal with the bacteria that might have been introduced into the wound in these cases. So you're going to find mast cells are also going to be releasing, in addition to macrophages, releasing these cytokines. Again, these are going to be chemicals that are going to help to travel into the bloodstream. They're going to allow for either one to kind of try to enhance the inflammatory process here. You're going to find there's a lot of sort of positive sort of feedback loops to kind of happen here. You're going to find that it's also going to help to induce tissue repair. You're going to find this also goes to the bloodstream to try to attract other sort of immune cells to the area, right? So this is how you can attract more neutrophils to an area, how you attract other types of cells, which is good. And again, because our macrophages are good as being phagocytic cells, but also the neutrophils are going to be another big component of that, and they usually are going to be the first things that show up as far as like new cells getting to the area. You're also going to find that our complement proteins are going to be activated, which also attract those phagocytic cells. We'll talk about that more in detail a little bit later on. Neutrophils can then release some mediators that are going to attract more monocytes, and then also we're going to find T lymphocytes tend to be sort of the last guys to arrive. They're kind of the last ones on the scene. Because again, neutrophils, as you imagine, they're a lot more predominant within the bloodstream. They're just present. They can get to the site much more quickly. Usually, you might have to have T lymphocytes coming from the lymph tissue, traveling to the bloodstream to get over to the site of inflammation. All just depends on kind of where it's at and what's going on. This graph's pretty good. So looking at kind of inflammatory intensity here on the y-axis versus looking at time, you can see here that usually neutrophils are going to be sort of the first things that show up within the first couple hours or so. And again, you already have some immune cells that are there. You already have macrophages and mast cells that are starting the process off. Notice how you're going to recruit more monocytes later on, usually say 12 to 18 hours afterwards. And then you can have your T lymphocytes showing up, maybe days later, essentially, right? So that's where they finally are going to be present there. And again, some people are like, man, I hurt my foot or something, or I, injured myself. you know, on day one, it didn't really hurt that bad, but what do you kind of notice the next day? Does it hurt worse or less? It tends to hurt worse, right? And that kind of makes sense because if you're causing this inflammatory sort of site, you know, twist your ankle or whatever it happens to be, like you're in recruiting more of these inflammatory cells to come in and cause that inflammation. Because of this time it takes for these cells to actually migrate over, it makes sense why things get more painful as time goes on, because you're getting more inflamed, you're having more of these cells rushing in, you're getting you know, more of these. Remember those free nerve endings we talked about that mediate pain? Like those get more sensitive due to things like substance P and whatnot. So again, this is a big thing you see where, you know, usually injuries hurt worse kind of the following days because you're having more of this inflammatory cascade. They're attracting more cells essentially. Again, looking at something like an activated macrophage, some of the products they're going to be releasing, these are going to be important to know as far as kind of what different sort of products these inflammatory cytokines are going to be. We have things like TNF. Anyone know what that stands for? That's tumor necrosis factor. Good. So tumor necrosis factor. We have IL-1. Anyone know what that means? Interleukin. Yeah, these are going to be very important inflammatory cells. These are going to be affecting things like endothelial cells. This can cause things like the capillaries to become more leaky to allow for easier travel of some of these cells into the site of inflammation. And then you're also going to have these colony stimulating factors, right? Normally think CSF. What do you think? Yeah, I think cerebral spinal fluid. Whenever you see usually like GM or G or M, CSF, that is colony stimulating factor. These are going to be hormones that are actually going to be stimulating production of new inflammatory cells essentially, right? So again, when I say GM, that usually means for granulocyte, monocyte, colony stimulating factor. So that would both stimulate the production of new granulocytes, like your neutrophils, eosinophils, basophils, and then also with the monocytes as well be stimulated there. And then you can have individual ones specifically, so just a granulocyte colony stimulating factor or a monocyte colony stimulating factor. And these are products we can actually give to patients as well. So for instance, if I were to have a patient with like a leukemia, and leukemia is just what? Basically your white cells are just replicating kind of without any kind of sort of restriction there. So, you know, it's a pretty common type of cancer we deal with in kids. When we give drugs, we wipe out basically all those, or as many of those immune cells as we possibly can. But again, when you wipe out someone's immune system like that, what are they at risk for? Infection, right? So because we don't want them to die of an infection, we go ahead and try to stimulate their immune system to kind of replicate itself, to try to replenish itself essentially. And this is where we can give things like colony stimulating factors. So if you ever see a patient getting a colony stimulating factor, they're probably on some sort of treatment that has actually depleted their immune system, and we're trying to help to replenish it essentially, right? So we're trying to get a bigger proportion of healthy cells present in order to kind of reestablish that immune system to prevent infection essentially, right? But again, these will go down to the bone marrow and then stimulate the production of these new white cells essentially. Okay, I mentioned the mast cells are going to be degranulating. So again, they're releasing other kind of these vesicles full of inflammatory mediators. As we're going to see things like heparin. We mentioned, what does heparin do? It's an anticoagulant. It's going to, remember what enzyme it works with to help inactivate clotting factors? Yeah, antithrombin 3 helps antithrombin 3 to work faster. So that could be good because it can actually help for you know, keeping things from clotting up too quickly to allow for flow of some of these products to get to the site of inflammation. Could be one reason for it. Histamine, what does histamine do for us? So you think allergies, you think histamine, what's it doing in these cases here? So it causes inflammation more specifically, right? Because we're talking about inflammation as a whole here, but what is histamine doing? So think histamine, think of that edema that happens. Think about the redness that occurs when you have some sort of inflammatory event, right? This is usually causing vasodilation to occur, right? Histamine causes vasodilation. You're going to have a lot of these fluid coming up. It gets hot because, again, you're causing vasodilation, more heat, more blood's traveling to the area. That's usually the role of histamine. It kind of makes sense because when you have like seasonal allergies, what are some of the manifestations of that? And when you get like a stuffy nose due to allergies, or if you're around like cats or something like that, or dogs, whatever it happens to be, you can find that your nasal mucosa becomes very vasodilated, right? That causes edema and that causes nasal stuffiness, right? How about with the eyes? Whenever you have like any eye symptoms with allergies, what happens? You get really watery eyes, right? So again, that's another thing. We're seeing that vasodilation. You're getting more filtrate, more the fluid being filtered from the capillaries because they're more leaky at that point, right? Other things you can see is hypotension actually. So if you were to have, say, a system-wide sort of inflammatory event, say for instance anaphylaxis, right? So say for instance someone has an allergy to peanuts and they have exposure to peanut on accident. All of a sudden they get this full body sort of inflammation. Histamine is a big thing that's going to cause vasodilation, and a very common clinical sign of that is going to be hypotension, right? So you're going to measure the blood pressure super low. They're tachycardic as all get out, because remember, as I drop my TPR, my total peripheral resistance, what does the heart do to help with that? Increases rate, right? So it's going to beat stronger and faster, try to make sure cardiac output's good there. So anyway, see how it all comes back on itself, right? All builds on itself. Anyway, so histamine is very good as a vasodilator. It's going to help to kind of propagate this immune response here. We're seeing this inflammation, right? Other things you're going to find, cytokines is kind of a general term. Oh, yes, sir.
Where are the mast cells produced? Is that from the B lymphocytes or?
The mast cells themselves is actually kind of, I was reading up on this to prepare. I'm glad you asked this because I'm prepared for the right thing then. They used to think that the basophil, like once the basophils migrated to the tissue, that they turned into the mast cells. However, I guess they're upon further research, they're actually from two different cell lines essentially. So they're going to probably be more produced like in the bone marrow, I'd imagine.
So they don't have a relation.
They're very similar to the basophils, but you're going to find they're actually they are different enough to where you can't really say they're the same sort of cell there. But functionally, you can think of them as very similar cells to one another, right? Basophils, also one of the cells that helps to mediate inflammation. Mast cells are basically doing the same thing. But mast cells are going to be located in the tissue, and they degranulate, and they allow these inflammatory mediators to be released, essentially, right? But other things like tumor necrosis factor, that's also going to be another big one that's going to be playing a role here, causing a lot of inflammation. So anyway, so again, producing a lot of warmth, swelling, and pain. And again, when you release these cytokines, you're typically sensitizing those free nerve endings and making them more sensitive, more likely to develop those action potentials to travel up to the brain. Anyone remember which pathway they take? Pain fibers? The anterolateral pathway, and they would travel up and say, hey, we got pain happening here, right? Again, don't dump everything you learn. Some of it comes back up again. Okay, so then we have our neutrophils kind of being attracted to the site because of all these cytokines that have been released by the mast cells and the macrophages. These are going to help to kill the microorganisms, whatever happens to be usually through phagocytosis. And they also can release this product called neutrophil extracellular traps, or this helps to trap pathogens. So I guess whoever came up with NETS as an acronym was probably pretty proud of themselves, I imagine. And then they can also, once they are kind of used up, they kind of undergo this programmed cell death, usually causing that pus to develop. So that's usually, when you see pus in a wound or something like that, it's usually going to be degradation of a lot of the inflammatory white cells, right? And then they can also draw other monocytes to the area. So again, neutrophils show up first, and they can release products that will attract more monocytes to the area that can then work as macrophages, essentially. And then monocytes become macrophages, and then as you progress is where the lymphocytes are going to start to get involved. This is where we can see like B lymphocytes are going to start to produce antibodies, especially if they can develop immunity against a particular type of bacteria. This is where this can start to occur as well. Okay. And so looking at inflammation, so you can imagine, you get a lot of redness, a lot of warmth. This is mainly due to histamine causing a lot of vasodilation. So anyone know what type of infection this might be? I don't know where the picture actually came from. This is one I inherited. Maybe like a pericarditis, maybe like a mumps or something. Who knows? But yeah, they're getting that inflammation. They're seeing that vasodilation causing a lot of that edema that's actually happening there. This is probably something like a rheumatoid kind of patient, an autoimmune sort of patient is developing a lot of swelling up in the knee. I saw one kid in the ER that was coming in. He's having intra-articular corticosteroid administered, but they wanted to drain the fluid off of this knee first. He's like probably 10, 11 years old, so it wasn't a big kid by any means, but the rheumatologist came down and he placed a needle on a syringe intra-articularly, and I swear this knee, he drew off at least like 200 cc's of fluid off this kid's knee, and of course, like all that pressure, does that feel very good? Very painful, no. So when he started to pull off all this fluid and just kind of gross, nasty, just inflammatory looking sort of fluid, pulling it all off, and the kid was like, oh man, I feel so much better, all the pressure's gone. And then we give him a steroid to help kind of limit more inflammation. But this is something you might see more commonly with something like rheumatoid condition or some sort of autoimmune condition, right? The joints can be affected there. We'll talk more about that a little bit later. But other things you're going to find, pain's going to usually be mediated through release of things like prostaglandins, like PGE2. We mentioned that as being a product of the arachidonic acid pathway. Remember what enzyme helps to produce prostaglandins? Remember that COX enzyme, right? That's again where our NSAIDs like ibuprofen is going to come into play. So again, we'll talk more about that in other classes, but just know this is where like when you hurt yourself, if you like twist an ankle or something, that's why you take ibuprofen for it, because that helps to reduce pain by decreasing this inflammation, by decreasing these prostaglandins being actually produced here, right? And I mentioned the pus usually going to be due to phagocytosis of the neutrophils when they autolyse themselves. That's where they generate these waste products, this pus essentially. Okay, so again, looking at sort of the summary of events of local inflammation, looking at the innate response. Normally, the bacteria can enter in through a break in the skin. You're going to have the resident phagocytic cells are going to start to activate. Now, again, is this an adaptive response? No, this is something that's just innate. It would happen regardless if you had immunity against anything or no immunity whatsoever, right? It's a very non-specific activation. Also, the complement system is non-specific in this case as well, right? So again, you're going to have non-specific activation of complement. And then you're going to be looking at the specific immunity that comes along later on. It's going to be a delayed sort of response. You have B cells release things like antibodies. You can have the phagocytosis can be enhanced. So especially when you have like bacteria that have certain antigens that antibodies will bind to, that can make phagocytic cells more likely to gobble those cells and get rid of them, right? I mentioned extravasation, that diapedesis was what allows those new cells, new phagocytic cells, to cross those capillaries. And again, when you have things like histamine, they're causing vasodilation, it increases the size of those gaps, makes it easier for those cells to cross in those cases, which is very useful there. And again, redness, warmth, swelling, pain, that is all what you would expect to see in a normal sort of local inflammatory reaction. Okay, so any questions on that? If not, let's take a break and we'll come back in 10. So any questions from the first half regarding kind of local inflammation at the site? All right, so moving on to more of the humoral sort of immunity here, talking about our B lymphocytes. So again, we mentioned these are good for helping to generate antibodies, which are going to be targeting all sorts of things. But again, this is an adaptive sort of response. You need to have sort of an initial challenge to the B lymphocytes before they're going to start to generate a whole plethora of cells. They're going to be able to release these antibodies here. So there's a couple ways that this actually occurs. So you can see right here, imagine here's like an invading microbe. Notice here they have all these little kind of red dots on the end. These may be specific proteins, but these are kind of generally antigens essentially. They could be polysaccharides, they could be glycoproteins, could be really anything. But basically they are usually need to be a large enough molecule that it can be, you know, usually identified by some of these cells here, some of these B cells. So either the antigens can be potentially released by the bacteria itself and can interact with the B lymphocyte directly. And again, these are interacting with antibodies that have been located on the cell surface. And again, usually these antibodies are going to be the one that the B cells will then produce on its own, right? Or you could have something like the macrophage as it is degrading these bacteria. Maybe it can then have the antigens kind of separated on its own and then release that out and then interact with the B cells. Or in some cases, you're going to find that we're going to see that the T helper cells and other T lymphocytes are going to be very useful for this. Anywho, so basically either way, you're going to find that these are going to, as these B cells get challenged, they're going to be undergoing multiple cell divisions at this point. And then what you're going to find is they're going to undergo two main pathways. One of them are going to be these plasma cells. Plasma cells are going to be able to generate a lot of new antibodies. You can kind of see these here. These are going to be the plasma cells that are releasing a ton of antibodies that can then go and bind up all those antigens on whatever the pathogen happens to be. The other cells are going to become what? Those are going to be the memory cells, right? So that's why you're going to get a stronger response the second time you have exposure to a pathogen, is because now you have these memory cells and they're going to be much more quickly able to elicit a response rather than having to deal with kind of this initial response where you just maybe happen chance have one of these antigens binding up to a B cell, right? You have a lot more of these cells available to generate new antibodies and can neutralize that target a little bit more quickly, essentially. Again, just another picture showing this. So again, antigens binding to the actual receptors themselves. This is then going to cause a proliferation or this mitosis to occur, rapidly dividing, and then you're going to have some are going to be activated plasma cells, which release the majority of the antibodies here, or they're going to become memory cells that can be used for later on, right? So again, that secondary response tends to be a lot stronger. Which is why, imagine if I were to give a vaccine to something, like say for instance I was going to give like the meningococcal vaccine, you may see with the first dose I'm mainly going to be activating these original B lymphocytes, and then I can trigger off that proliferation, and then the next time I give say the second dose in that series, I'm going to be trying to elicit a response from the memory cells to get an even stronger response the next time. So that's why sometimes you'll see with vaccines you have to give multiple doses. That helps to get a stronger and stronger response because you're kind of priming the pump, so to speak.
So memory cells are just differentiated plasma cells?
Say it again?
Are memory cells just differentiated plasma cells?
Yeah, basically they're just dedicated to kind of sticking around. They're not going to be producing as many antibodies. However, when they get hit with that antigen again, then they can undergo that mitosis and produce new plasma cells.
Do they replicate, or do they just kind of like stay in your immune system forever?
The memory cells, they probably have some degree of replication, but probably not as quickly as you would see when they are challenged with the antigen, so to speak. But they do have a certain lifespan. Typically not as long as you're going to see with the lymphocytes, the T lymphocytes, but you know, they're able to replicate enough to kind of keep that response around, essentially, right? Because if I wiped out all those plasma cells, all those memory cells, and potentially I could lose that response to it over time. And that's why you can see with some vaccines, you lose immunity over time if you were not to get a booster, essentially, those titers of those antibodies could actually go down over time, and you can actually lose that immunity, so to speak. So could it be related to maybe a lack of replication of these memory cells over time, possibly? Do you have a question in the back?
Memory cells, how do they usually in lymph nodes? They just stay there until
they can hang out there. Yeah, they're not usually going to be circulating to the same degree as some of these other immune cells we're talking about. Usually in the lymph tissues where they're going to be hanging out. Okay, so again, looking at, say, like the first antigen injection, so you were to inject your patient with an antigen. And again, when would I ever inject a patient with an antigen? That sounds kind of mean. That's a vaccine, essentially, right? So again, when I'm injecting a patient with a vaccine, that's basically giving them the antigen. They're then producing that primary response, and then if I wait a period of time, say 30 to 60 days or so, and then I give them a second antigen injection, that secondary response should be much stronger, because now I have all these memory cells that can be activated to produce new plasma cells, essentially. Okay. And so the antibodies, 5 main types we're going to talk about here. Some of these are going to be a little bit more clinically important than others, but these are also kind of known as immunoglobulins. So if you ever hear of a patient receiving immunoglobulins, basically they're receiving one of these. There's IgG, IgA, M, D, and E, and each of them have their own specific sort of role here. So for instance, IgA is secreted in the saliva and also in mother's breast milk. Why is that important? Yeah, so how good is a baby's immune system when they're born? Not great, right? So again, they don't have a lot of learned responses yet. They have still some innate immunity, right? They have some ability to deal with infections. However, they don't have a lot of the antibodies that mom is potentially producing here. And this is where IgA can be very useful, and which is why you have to be careful, especially like maybe kids who are not being breastfed. They may not have all that IgA around, right? They may be more susceptible to certain types of infections. And also it can depend on what mom's kind of immune to begin with. But again, it's one of those things where you can provide an additional protection if the kid's getting fed breast milk, right? IgE we're going to see is going to be important for allergic symptoms, especially during hypersensitivity reactions. So if you hear like anaphylaxis or something like asthma, it's usually going to be mediated through IgE. And actually when you're monitoring a patient for allergies or for asthma, so we have like an immunology clinic that we have over at Nemours, and something they'll do is they'll actually measure IgE levels for these patients, and the higher those levels are, what do you think that would mean for their asthma? Yeah, so they're more likely to have exacerbations. They're more likely to see flare-ups, essentially, because they have higher levels around. They're more likely to react to things, essentially, right? So IgE is important for immune, allergic sort of reactions. IgM is going to be usually present on lymphocytes prior to immunization. And you're going to find these are going to be secreted primarily during that primary response. So again, when those B lymphocytes initially get hit, they're probably going to be releasing mostly IgM at that point. And then on further re-challenge, you're going to find that IgG is going to be the main role here. And if we're giving a patient immune globulin, typically we're giving them IgG in those cases there. So if you ever have a patient had like some sort of primary immunodeficiency where they're not producing their own immune globulins, usually what we're doing is giving them pooled immune globulin that we actually get from like donated plasma, donated blood, and things like that. We'll pull all that together, all these different people's antibodies, essentially, most of which is going to be IgG, and then we can give that to a patient to help them fight off infections potentially. So sometimes we'll have patients who have immunodeficiencies like that. Again, one other thing to consider though is whenever you have products that have been pooled from donors, what do you have to consider for a patient who's receiving that? Because again, usually you worry about like infection and things like that, but we take care of that. They are usually made so they're very sterile, and they're not going to give diseases to the patient we're administering them to. Anyone have any like religious considerations? Yeah, to worry about like Jehovah's Witnesses are the primary one I think about, where they do not want to receive blood products from other people, and this is one thing where they couldn't receive IgG potentially because it's blood products from another person potentially, right? So it's always a consideration, always something you want to check on before you ever give a patient blood or a product like this. Anyhow. Again, we also mentioned IgD. This is typically going to be located on certain lymphocyte surfaces prior to immunization. Again, we don't use this one. This one doesn't come up as much clinically, but definitely knowing G, A, E, and M are going to be pretty, ample, ability to test on that sort of thing. So know those for sure. Again, D is not as clinically going to be relevant for our purposes. All right. So looking at, for instance, you're looking at, say, a T helper cell, which we'll talk about more about these in detail in just a few minutes here. But you can see that when you have an antigen being processed here, we're going to find that T helper cells can be very useful for helping to present some of these antigens, helping to release things like lymphokines over to the B cells, where then they can be responding. And once they produce plasma cells, we mentioned during the initial response, it's typically going to be what? So before you have like immunity, typically IgM, right? And then afterwards it would be what? Yeah, I use IgG, but again, they can release other types of immune globulins as well. It's just those are going to be the predominant ones in those cases. Remember, like breast milk, think IgA. Think allergy, you're going to think IgE. We'll talk more about allergy a little bit later on. So up next, we'll talk about the complement system here. And again, it's like the guy who goes to the bar and hears someone go, "Hey, you look really nice today," and he's like, "What the heck was that?" And then the bartender says, "Oh, the peanuts are complimentary, right?" Not the same kind of compliment. I know I made that joke already, but I just wanted to tell that one. But the main things to know with this is that usually there's 9 basic different complement proteins here. I'm not going to get as granular with this as we did for, say, for instance, the clotting cascade, right? But it's good to know kind of what the general purposes for these different complement proteins are going to be, essentially. So again, C1 primarily going to be a sort of recognition sort of protein. This is typically what you're going to see is interacting with the pathogen in order to kind of kick off the whole process here. So imagine you have like an antigen antibody complex. This is one way to kick off the complement system. C1 is usually going to be the first thing that kind of recognizes that, so to speak. 2, 3, and 4 are going to be activators. They're going to kind of help to propagate the system and get it ready for kind of the final step, which is where C5 through 9 are going to be actually going to the cell membrane and can actually cause lysis to occur. So you can actually see these either call what we have opsonization, where it actually makes it more readily available for macrophages and other phagocytic cells to eat up the pathogen. In these cases, 5 through 9 are going to be very helpful for actually helping to basically punch a hole in the cell membrane. And when that occurs, all the contents lyse out, and you're going to find the cell dies essentially, right? We actually have certain antibiotics that do very similar things, but this is our own sort of innate sort of immunity that can kind of help with this with the complement system.
So does the complement protein die with it, or does it just?
I actually don't know if they probably get used up. I imagine you're always producing new complement proteins. I imagine it's probably a one-time sort of use. It's not like antithrombin 3 that would like inactivate clotting factors and you can reuse it. But honestly, I have not ever thought about that. So maybe if you find something different, you can maybe report back to us and do some lit review, maybe. Didn't know you signed yourself up for a homework assignment, right? I'm just kidding. No. That's okay. Inquiring minds don't really want to know. So there's a couple of different pathways here. So basically this is how you're sort of kicking off the process here. We're talking about the classical lectin and this alternative pathway. But again, the terminal aspect here is what you're going to see is that C3 is going to be getting activated, and then 5 through 9, that's actually what's going to be binding to the cell membrane, either causing the lysis to occur, but the primary thing you're going to see there. But again, this is all part of the opsonization process as well. Makes it much more likely for the phagocytic cells to want to eat up the pathogen. I know this is kind of, notice like an amplification loop. What would you consider that to be an example of? The positive feedback loop, right? So again, by causing that amplification, it's going to cause further activation of some of these other precursor complement proteins, and then that's going to lead to more C3 being activated. You know, so again, it's more of a kind of a positive feedback loop in those instances. So these pictures are pretty complicated, and again, that's why I didn't want you to memorize like the entire cascade of how each protein is going to be utilized here. But again, 5 through 9, it's mainly going to be punching a hole in the cell wall. 1's going to be the big recognition protein, and 2, 3, and 4 are mainly going to be for kind of stimulating the process and kind of working through it. So the classical pathway is typically what you're going to find is that these complement proteins are going to be activated when you have things like the antigen and the antibody binding here, right? So if you were to produce an antibody that binds up to the antigen on the bacteria, that can then activate off C1. That can then start the cascade here. Right? So that's kind of the classical sort of process here. There's a few other ones like the lectin pathway, where actually by having certain carbohydrates on the cell wall of the bacteria, that can also kick off the process here. Again, the intermediary steps are a little bit different, but again, the end result's always going to be 5 through 9, kind of getting there onto the cell membrane and punching a hole through the wall essentially, right? There's also an alternative pathway. This is basically where you're going to find that complement is actually interacting with the bacterial surface itself. It's not really an antigen or like a carbohydrates binding to, but just to the cell membrane in and of itself. And here's another kind of table showing you how the steps are all kind of breaking down here. But again, once you have the C3, that usually is going to be kind of kicking off that terminal pathway, whatever happens to be. So, for instance, we have like C3b. This can kind of help with that opsonization of the pathogens, right? But 5 through 9 is mainly going to be that membrane sort of attack complex there. So 3 kind of helps more with the opsonization process. You may find that other sort of like phagocytic recruitment and inflammation may be mediated to like 3 and 5. But the primary thing, just note that 3 is good for opsonization, 5 through 9 good for cell lysis. Because again, in some cases, you're going to find that just by binding an antibody to the antigen, does that really do anything to it? Does that actually kill the cell off? Not necessarily. Usually what you're going to find is it can either neutralize it, maybe make it less potent of a pathogen, or in some cases you're going to find that it's going to be kicking off other sort of inflammatory pathways, like the complement system. Basically, by having that antibody bind to the antigen, you're targeting it for destruction later on by the complement system or by macrophages. But again, just binding an antibody to an antigen does not necessarily do anything in and of itself, right? So again, 1 through 9 are the main proteins. 1's going to be the recognition. 2, 3, and 4 kind of kicking off as activators. 5 through 9 good for actually binding to the cell wall, causing lysis. The classic pathway, again, we kind of went through this already, so I'm not going to belabor that, but that's usually we're going to find the classic antibody binding to the antigen. Again, with like something like the lectin pathway, that's where it's actually binding to a carbohydrate on the actual cell surface. You actually don't need an antibody in that case there. That would be something that wouldn't require sort of like a learned sort of immunity in that case. You can go, again, that would only be for certain bacteria that maybe are presenting that sort of carbohydrate in the first place. And notice here, usually IgG or IgM are going to be the main antibodies here that are binding to these bacteria or whatever pathogen it is to kind of kick off this complement system. Okay. Again, anytime you're punching a hole in the cell wall, that's going to be causing, anytime you're kind of disrupting bacterial cell walls, things like that, that's going to cause eventual cell death. Because again, just like if I punched a hole in you, would you live for very long? You know, you probably spill out all of your contents and then that'd be it, right? Anyone ever seen the movie Kung Pao? The guy has like a hole punch like straight through him. Like that guy wouldn't probably live for very long because he had a hole straight through him. So the same thing happens to bacteria, right? It's a good way to kill them off, and that's what we call cell lysis essentially. Okay, any questions on that? Moving into the function of the T lymphocytes. So first ones we have here are going to be our killer T lymphocytes. I think Queen had a song about this, right? Killer T? No? Okay. Anyway, these are also going to be considered our CD8 cells. Sorry, a little classic rock joke for you guys that no one was alive for when it was written. But anyway, CD8 cells. So basically, CD8 cells are going to be having these CD8 co-receptors. They're going to help for kind of binding to sort of an antigen sort of presenting cell and helping it to be identified as something like either an infected cell or maybe some other pathogen we're going to be getting rid of, right? So for instance, if you had a cell that was infected with, say, like a virus or a fungus, or maybe potentially like a malignant cell, a cancerous cell that is presenting some sort of receptor or protein that the CD8 cell can bind to, it can detect that and it'll just say, hey, this is going to be targeted for destruction. We need to get rid of this. And so it can cause eventual cell lysis. It's not actually phagocytosis happening here. It's actually just kind of causing eventual cell destruction, usually kicking off like apoptosis from occurring and things like that to cause the cell to eventually die. Some better pictures here I'll show you in a second. But we also have our helper T lymphocytes. These are going to be considered our CD4 cells. Anyone know where, like, what disease state CD4 cells are really important for? You know, like viral infections. HIV is a big one, right? So whenever you're talking about, again, HIV patient, you're talking about CD4 cell count, because this is actually the type of cell that the HIV virus is actually going to be specifically targeting, right? We'll talk more about HIV later, I believe, like in Pharm 2, and you'll cover like an infectious disease and all of that. But the CD4 cells are really important for that. And that kind of makes sense why a patient who has really kind of progressive HIV and they're getting to a point where they have depleted a lot of their CD4 cells, what do you think happens to their immune system? Is going to be very suppressed, and actually you're going to find that they're going to be much more likely to have what we call opportunistic infections. That's where you have a normal bacteria that doesn't normally cause disease in healthy individuals. However, they have their immune system suppressed enough. That's where you run the risk of developing that. So this is a case where they run out of CD4 cells. They're not able to actually activate a lot of these different pathways and getting infections from that. And then HIV normally progresses into AIDS, right, which stands for acquired immunodeficiency syndrome, right? So it's immunodeficiency is right there in the name itself. So when you have someone developing these opportunistic infections, that's where it makes that transition from just having the virus to actually having the immunodeficiency. Anyway, a little bit of a tangent there, but the CD4 cells are really important for that. So what they're going to do is they actually help for improving the ability of the B lymphocytes to become plasma cells. So if you imagine, to say something like, you know, an activated T cell either becoming a T helper or T suppressor cells, we'll see, or T killer cell. Having those cytokines are going to start to being released from the T helper cell can actually cause the plasma cells to release more antibodies. That's one of the primary things you're going to see with that. Some other cases here we're having like a CD4, and there's this kind of co-receptor here. That's where the CD4 actually comes into play. By releasing those lymphokines and things like that, that can either try to activate the cytotoxic T cells. We talked about those, or potentially just activate the B cells. So again, these are very, they're supplementary. They're not actually destroying the cells themselves, but they're kind of activating off or kicking off, you know, the B lymphocytes and other T killer cells in order to activate and actually deal with whatever the pathogen is. So these are absolutely critical. If you're missing these, you're going to be immunodeficient to a very strong degree there. Again, showing you the difference between like a T helper cell having the CD4 co-receptor versus like the CD8 co-receptor. Basically, when you're having, say, like a target cell or something with like a presenting a particular antigen, you're going to have these ability to bind to certain certain sort of proteins here, and again, there's some specificity to these as to what they'll actually bind to. But once that co-receptor kind of digs in there as well, that's when it says, okay, I'm recognizing this as an antigen. I'm recognizing this as a foreign protein or an infected cell. I need to go ahead and activate the B cells. I need to activate some of these other CD8 cells, these killer T cells, right? So that's basically how these T helpers are working on. Again, their functions right there in the name, essentially. A picture kind of showing the same thing here, the T helper cells. Then here's your CD8 cells that are going to be able to recognize that as well as being maybe a tissue infected with a fungus or virus, whatever it happens to be. And then this will trigger off that destruction of the infected cell, right? That's ultimately the goal we're shooting for here. Again, looking at kind of the antigen detection in general, starting off with stem cells, again, either developing into a B lymphocyte or T lymphocyte. Notice here that B lymphocytes are going to be helped by the T helper cells, so it's going to have a positive influence on that, so T helper cells help with that. You're going to find that sometimes you have kind of regulatory lymphocytes that help to prevent maybe an overactive immune response from the B cells, but typically T helper cells are the main ones we're going to focus on here. And then T helper cells are also helping out with the killer T cells. They're going to help, and those CD8 cells are going to help to fight off those cells as well, right? Okay, so some of the cytokines that can be very useful for helping with this process are going to be our interleukins, and you think that kind of makes sense because it's between leukocytes, between white cells. It kind of makes sense how these are operating here. You can find that their function is going to help with things like proliferation, activation of things like T lymphocytes with IL-1, IL-2, things like IL-4 would be helping to promote production of IgE. What do you think that would be useful for? Yeah, it'd be more like allergic sort of reactions, right? So that'd be one thing. IL-5 would activate some of the CD8 cells there. IL-6 would cause proliferation of some of these T and B lymphocytes. And in fact, we have certain drugs that are actually designed to neutralize certain interleukins, right? So we actually have, if you have like an autoimmune condition, which we'll talk about in a minute, by neutralizing some of these, you can actually help to prevent that overactive immune system from attacking your own cells and prevent it from causing more inflammation. So we have a drug called Actimra that will actually come in and bind up interleukin-6 and neutralize it to prevent it from causing this proliferation and activation of T and B lymphocytes, right? And in fact, if you ever hear a drug that ends with the letters MAB, anyone know what that means? Which means monoclonal antibody. It's usually like an antibody that we've developed as a people that we give to other individuals to try to neutralize something. In this case, it would be like IL-6. But again, we have all types of drugs that can affect these other interleukins. Kind of have a general sense for what these are doing and what their function is going to be as far as either influencing B lymphocytes, whether they're influencing IgE production, things like that are good to know. Just another table kind of showing you a similar thing, what these functions are going to be, so you can refer back to that if you need to. Okay, so going and talking about active and passive immunity. So when I say active versus passive, what do you think that means? Passive, you just sit back like, you can infect me, it's fine. I didn't want to live anyway. No, not like that. No, it's right. So active immunity is immunity that you're actually generating yourself. So this is part of still the adaptive immune response, but it is something that we have generated ourselves. So if you get sick with chickenpox, do you get chickenpox again? No, you develop immunity against it, right? We also have vaccines that can help with that, with varicella and whatnot. But what you're going to find that is an active immunity. You have developed immunity yourself. Typically, when you're giving vaccines, this is a form of active immunity, right? And again, after infection, maybe takes 5 to 10 days or so before those really antibodies start to be detected in a large number. However, that's when the person gets sick, right? Because they don't have the ability to fight off that infection on their own. As antibodies start to get produced in a higher number, this is where you can start to get more inflammation, more ability to fight off the infection. However, if you were to be re-exposed to that same pathogen again, you're going to notice that if you were to develop immunity to that, all those memory cells are going to be much more able to start to kick off their response. Antigens can be detected at a much higher level, and then you're going to be able to basically not get sick that second time, right? Because you have a much stronger response there. So that is an active response that you've developed yourself. Okay, so something like vaccines would be a form of active immunity. Something like actually getting the illness yourself is a form of active immunity. Okay, so on that regard, what do you think would be a passive immunity? Okay, yeah, so from mom to baby, it'd actually be a very good example of a passive immunity. So again, that baby has not produced antigens themselves, or the antibodies themselves. The mom has basically kind of loaned it to the baby, right? So again, development of secondary immune response provides that active immunity. Again, you can lose this over time. However, being re-exposed and getting sort of a booster sort of effect can be useful at helping to retain that durability of that response there. Yes, sir?
Does live versus dead vaccine have any impact on that?
We'll talk about that right on this slide, actually. I think either on this slide or the next slide. But yes, we will talk about that. But again, you need to have like a prior exposure to the antigen to get protection in the future, right? So again, in some cases, you get the illness, you get sick. However, you don't get sick a second time. Or if we were to give you a vaccine, we'll talk about the different types and how we actually prevent you from getting sick. Because when I give you, say, for instance, the tetanus vaccine, tetanus, usually the vaccine usually contains diphtheria as well. Do you normally get diphtheria from that vaccine? You don't. We'll talk about why that is in a few minutes here. Usually our goal is not to give the patient the disease. However, has anyone ever heard the complaint like, oh man, I got my flu shot and then I got the flu immediately after? It's actually not the case, but I will tell you why that isn't in just a few minutes here. Anyway, I'm not sure if anyone has strong opinions on vaccines. I will give my children every single vaccine under the sun because I think they are very well and good. And so we're going to go from our standpoint, we're going to say, yes, vaccines are effective and generally take a pro-vaccine sort of standpoint, okay? So I don't know if anyone has any strong feelings the other way, but if you'd like to talk about it, we can certainly do that. Private or in public, whatever you like, we can talk about it. Anyway, always encourage lively scholarly discussions. Anyway, but yes, this active immunity, this is where kind of the basis for our vaccines is where it's come from, is trying to develop an active immunity in our patients, okay? Normally when we're giving a vaccine, though, we're going to find that it's not actually virulent, it's not disease-causing. So by inactivating it in some form or another, you prevent it from actually giving the patient disease. So for instance, I don't give people polio when I give them the polio vaccine, and that's because I've made it basically inactive. So 3 ways we can accomplish this. I can use something like a killed virus. So for instance, if I can kill off the virus and then give that to the patient, they can still have those antigens there. They can still detect that, and they can still produce antibodies against it, right? So that would be an example of a killed vaccine, where again it can't cause polio because again those viruses can't replicate; they're dead already, right? You ever see the Muppet Treasure Island by any chance? And they said, "Dead Tom's dead." They're like, "Well, Dead Tom's always been dead." And they're like, "Oh, okay, that's no problem." Right? So basically, giving a killed virus, it can't replicate on its own; it's already dead. Now, you could potentially give an attenuated virus. What do you think that means? Yeah, so it's basically kind of like a weakened version, like a wimpy version of a bacteria or a virus. And so in these cases, you would find that it is weak enough that it actually cannot cause. It's still live. It's still alive and can replicate. So if you had to guess, what do you think would produce a stronger response between these two? Killed versus just an attenuated one? Yeah, the attenuated, because it can still replicate. You get a much more similar response to what you would see with actual disease in those cases. So that is one way we can also develop immunity. However, what if you had someone who had a really weak immune system? They actually are still at risk for developing the actual disease themselves. So in those cases, if you have someone who's like really severely immunodeficient, or if I'm maybe giving them a drug that's making them immunodeficient, I don't want to give them a live vaccine because they run the risk of actually developing the disease. Even though it's a wimpy version, it can still potentially cause disease for them because they don't have a good enough immune system to fight it off, right? So that's one thing, one caveat to note with that. And again, we'll talk more about that later on in the pharm courses. But the other thing we could be potentially doing is using a genetically engineered version of a virus. So for instance, we can make a recombinant version that is still having all of the antigens that our body needs to produce an immunity. However, it is missing maybe key components of it that would actually cause disease in of itself, right? So for instance, hepatitis B, maybe it's missing the components that would actually be necessary for it to infect the patient and continue replicating. It does not cause hepatitis in those cases, right? Now, however, I mentioned, people are like, oh, I got the flu shot, now I got the flu. Why do you think they would develop signs and symptoms of the flu after receiving something like a flu shot? So they could have had the flu already. That could be one thing. What's the other thing? The body's still reacting to that. You're still developing an immune response, right? So again, they have signs of inflammation that occur because they're still interacting with that virus, right? So in the case of, for instance, like the flu mist, anyone ever have like the nasal flu vaccine? That is actually the live attenuated form of the virus. You still have an immune response to that. So yeah, you may get a little bit of fever, you may get a little bit of runny nose or something due to that kind of body-wide inflammation. However, you also don't get the flu, which is much, much worse, much more likely to cause, secondary bacterial infections and hospitalizations and myalgias and all these other things. You don't get that sort of response. It may feel a little crummy for a couple of days, but tell them to take some Tylenol, they'll be fine, right? So anyway, those are the 3 main types you're going to run into and how they're actually developing an immune response. So again, this is still active immunity. You're still developing the immunity yourself. Okay, that's the key point there. And in fact, they'll actually do things like check titer. So working in the healthcare field, we are potentially at risk for developing, bloodborne or contracting bloodborne diseases from patients and things like that. So like hepatitis B is a big one. You'll get titers for it if you go to work in a hospital. They'll check you to make sure your titers are high enough to show you still have immunity. If you don't, if they're too low, what could they do? Yeah, they'll give you another booster shot essentially to try to reestablish that good immune response by trying to repopulate those memory cells essentially, right? Anyway, so passive immunity, passive just mean would be what? What would you think based off our discussion so far?
Passing antibodies.
Yeah, we're giving someone the antibodies essentially. We're giving someone the ability to have that response, that immune response. However, they're not producing it themselves, right? So basically, this is a temporary protection. So for instance, if I had someone who had like a primary immunodeficiency, they did not produce their own IgG, and I gave them a dose of IgG, that'd be passive or active? That's passive. They can still fight off infections, but it's going to be, as soon as those antibodies are gone, they're not producing it anymore. They're going to find that's a passive sort of immunity. Mother to fetus or mother to child, say with the breast milk, all of those are going to be examples of passive immunity, because as soon as the baby loses those antibodies, they're going to have to mount their own response in order to get that protection again, right? So again, that's going to be sort of a passive sort of immunity. One way that we use this very frequently, at least I do, from a tox sort of standpoint. Anyone who's not from Florida originally? We got snakes, I hate to tell you, but pretty nasty snakes. And so we have ones called pit vipers. They include like your rattlesnakes and water moccasins, things like that. Well, we have an antivenom that's actually for that. And basically what we do is we inject tiny amounts of snake venom into a sheep. It's actually an ovine-derived antibody. We'll inject the sheep, and they actually develop immunity against the venom. We will then take that out of the sheep, we'll spin it down, we'll isolate it, and then we can then give that to the patient. That is another form of so passive immunity, we're actually giving antibodies that will bind up that antivenom or that venom from the snake and prevent it from causing all kinds of clotting disorders and other stuff like that. So that would be kind of another form of antibodies that we're giving to try to neutralize something essentially, right? So that would be a form of passive immunity essentially. Okay. And we've never heard of like someone like trying to inject themselves, like let the snakes bite them so they get immune to it. It's kind of the same thing. We're giving the passive sort of version of that, right? Very expensive though. We don't have to do that if we don't need to. But we have a lot of dumb people here in Florida that get bit all the time. So hey, look at this, and then you bit. Anyway, actually, I went to a serpentarium just recently. There's one very famous one in St. Cloud, where I live. Fortunately, I'm several miles away from the serpentarium because my wife would not want to live anywhere near there. However, the man that was working there, he's kind of famous around certain ERs about getting bit quite frequently. And I realized why when I saw him, because he only had 9.5 fingers. So, gosh, like, you had some bites, my friend. Anywho. All right, so anyway, just comparing these two, again, with the passive immunity, we're usually giving someone the antibodies either through like breast milk or through placental transfer or through actual injections. With the active immunity, we're giving the person the antigens essentially to produce their own response to that. Okay, and again, which one's going to be longer lasting? Active immunity is always going to be longer lasting, but however, it's going to be taking time to develop that resistance. So again, if I were to give someone, say, the hepatitis B vaccine, they've never been vaccinated before, give them hepatitis B, they can still get hepatitis B in that initial period because they haven't produced the antibodies yet. However, if I was to give someone the immune globulin that was the antibodies that were designed to target hepatitis B, if I were to give that to them via an IV, would that take time to kick in, or would that actually just work immediately? Yeah, immediately. So again, as soon as I give them the antibodies, it kind of kicks in immediately. And so it's actually something you'll see, hepatitis B immune globulin. That's basically the antibodies designed specifically against that. But again, duration, a lot more long-lasting for the active immunity. Again, you typically want to use this before exposure. That's why if you like travel to various countries, you want to check to see if there's any vaccines you should get beforehand, because you want to get those vaccines when you're already there, because then you're already at risk for being exposed, right? Things like yellow fever and typhoid and all kinds of stuff like that. Okay. So looking at things like tumor immunology, so this is important because again, the body should be able to recognize self versus foreign. It should also be able to recognize things like changes in the cells and may mark them for future destruction. So for instance, some antigens provide the basis for like diagnostic blood tests. So for instance, when you're checking for prostate cancer, one of the things you can actually check for is going to be this PSA, right? So basically by checking the levels of this, based on the patient and whatnot, you can actually detect, okay, well, are they producing a lot more of this than they should be? It could be related back to an actual tumor they have in the prostate gland, right? Excuse me. A lot of these arise from things like mutations from like carcinogens. What's a carcinogen? Cancer cause. What's a good example of a carcinogen? Cigarettes. That's always the one that people go with, but probably anything can be a carcinogen in a long enough timeline, I imagine. But yeah, something that causes a mutation, something's going to be causing cancer there. So again, that could be what's causing the actual mutation in those cases. Some cases you may actually find that viral antigens from a virus can cause a tumor. So for instance, one of the first vaccines we had that actually prevented cancer was for HPV, right? There's certain subtypes of the HPV virus that can cause cancer, especially cervical cancer for women, but other anal cancers and colon cancers potentially, but the cervical cancer is the big one. But we can potentially vaccinate against that if we give a patient the ability to produce an active immunity against it, right? Normally, though, this overexpression should be producing an immune response, but that is not always the case. Again, we have lots of cancers that we're not treating effectively, especially with for instance, if you're dealing with like a leukemia, the problem with is already your immune system to begin with. So of course you can't expect it to fight itself off essentially in a lot of cases. So just an example, looking at like a T cell interacting with a cancer cell and eventually causing cell destruction to occur here. So it kind of triggers off apoptosis in those cases. And the natural killer cells are going to be really good for this. So this is related back to the T lymphocytes, but they're sort of a form of innate immunity on their own. And they really without the ability to recognize specific antigens, but what they are able to do is kind of recognize our host cells versus an abnormal cell or maybe a foreign sort of cell. And so this is where things like transplant rejection comes from, by recognizing foreign proteins. That could be a case where you actually cause a reaction to occur there. Again, cytokines released from the ear can also trigger off both the innate and also the adaptive immunity as well. So you get a lot of, again, they can kick off the entire inflammatory cascade just like anything else we've already seen there. So natural killer cells, part of that innate sort of immunity that we have. Okay, and there are some cases like we talked about immunotherapy. This is where it can actually kick up the patient's own immune system to help us fight off, say for instance, tumorous cells or maybe a virus or something like that. So for instance, by giving an interferon, a therapeutic interferon, we can actually cause someone to mount up an immune response and fight off, say, something like hepatitis C or potentially certain types of cancer. They're actually pretty nasty drugs. Before hepatitis C, does anyone know if there's a cure for hepatitis C? There actually is now. It's actually a recent medical development in the past few years or so, but they actually do have a cure for hepatitis C now. We used to have to give them the interferon to help the body try to fight off and try to help them prevent it from replicating quite so much, but it was a really nasty drug, caused really bad mood swings and all kinds of issues. Not a great drug, but it was a form of immunotherapy to try to help the body fight off the virus it couldn't do on its own. In a lot of cases, you will not find this to be a cure for cancer, but it can help to kind of tamp down the growth of the tumor, may be able to help it try to slow down to some degree. Okay, and just looking at different changes as time goes on, you're going to find that susceptibility to cancer can vary pretty greatly. So, for instance, like things like prostate cancer or other things can tend to get more likely as you get older and older, and that's why that's why you have certain screenings, things like colon screenings and prostate screening, things like that as you get older, because we know that cancer risk increases with age. And in fact, on a long enough timeline, everyone is at risk for cancer, right? Because again, the more mutations you kind of develop over time, the more likely you are to develop that. But again, you can find things like thymus function might be reduced, maybe more likely to develop that. Tumors tend to grow a lot faster when you're under stress, especially because we mentioned that when you're under a stress sort of situation, you have a lot of cortisol. What does that do to your immune system? It suppresses it, right? So again, that can give the chance for things like cancer cells to potentially continue growing kind of on its own, essentially. So again, always remember, anytime you're giving someone steroids or giving them something like a glucocorticoid, just know that infection is always going to be a big risk with this, because we know it's going to be inhibiting the immune system, right? Okay, so let's look at some diseases caused by the immune system. Just a little bit of an example, maybe a little bit of a preview of what's to come in future classes. But autoimmunity is a huge set of diseases that can have many different manifestations. I'm sure you guys are already familiar with a few of them to begin with. But again, this is basically where our cells are not able to really tell self from foreign, and so our cells start to attack us, right? And so you can see things like, for instance, when you have these immune reactions that are occurring in someone, anyone know what this might be a manifestation of? Yeah, it's RA or rheumatoid arthritis. You can see joint destruction that happens over time because the body's starting to detect these cells there, and the joints are being foreign when they're really not, and they start to cause this whole inflammatory cascade. You're getting these lymphocytes involved, you're getting all of these inflammatory cells. Other common ones include things like diabetes type 1, multiple sclerosis. Anyone know what multiple sclerosis, what we're attacking? Yeah, central nervous system, mainly the myelin sheaths along the neurons. That's one of the big things that gets hit there. Lupus is another big one, psoriasis, lots of different thyroid conditions can be caused by this. And again, how do you think is the best way we can treat this? So if the immune system's overactive, we want to suppress it, right? So how can we do that? Steroids, right? So again, you'll find that the cornerstone for a lot of treatments for this is actually going to be giving something similar to cortisol, or giving something that has very similar functions to try to help inhibit the immune system. So what do you put them at risk for? infection, right, along with the diabetes risk and all kinds of other metabolic conditions. Steroids are really nasty drugs, but sometimes you have to use them, right? So just some other examples of autoimmune conditions. So for instance, you have things like Graves' disease. This is kind of interesting because Graves' disease usually causes hypo or hyperthyroidism. Anyone know? Actually, hyper. Anyone know why? It actually produces antibodies that will stimulate those TSH receptors. So you actually are stimulating the thyroid to produce more T3 and T4. Kind of interesting. Antibodies are just able to interact enough to cause that to occur. Versus something like, where's it at? I put it on here, but Hashimoto's thyroiditis, like that's another case where you actually have destruction of the thyroid gland over time because they actually have antibodies against the actual thyroid gland itself, right? So again, it just depends on the manifestation of the disease. You can sometimes have increased effect of the organ, or in most cases, decreased effect for the most part. But certainly we run into a lot of cases like rheumatic conditions. You know, we have a lot of JRA, which is juvenile rheumatoid arthritis. So again, rheumatoid arthritis is not just something that affects old people, it can affect very young people as well. So I deal with that quite frequently. Things like Crohn's disease and ulcerative colitis are very common GI issues that we deal with. You know, I mentioned type 1 diabetes. What's happening with type 1 diabetes? It attacks beta cells, destroys those, and guess what? Now you can't produce any insulin, right? So now we have to give you exogenous insulin the rest of your life. So again, lots of different varieties of this, and you'll sometimes find that the therapy is going to be very similar amongst the different groups here. So we'll find there's a lot of bleed over, especially when we get into talking about this in farms, a lot of bleed over the different drugs. So, okay, so finally we'll talk a little bit about allergic before we break for lunch. What's happening here, this guy? That's allergy testing. So this is where we can go through and prick them with all different types of potential allergens to see what the patient's having a response to or not, basically. And so again, this is something we'll do sometimes with our immunology clinic over at Nemours. But basically, when you see these allergic responses, also known as a hypersensitivity, again, you're hypersensitive to something. We'll talk about it both immediate and delayed response hypersensitivity here. So immediate hypersensitivity, this is where things are going to be happening very quickly. This is where you might imagine things like food allergies, or if you imagine bee stings or pollen, seasonal allergies, animal dander, things like that. This is going to be more of an immediate sort of hypersensitivity here. And what you actually see is the antigen itself, once it's crossing over and starting to interact, you may have certain antigen presenting cells. You may have certain cells that can actually show up that antigen and can get some of the T helper cells involved here. Or potentially you can actually have the antigen bind to things like the mast cells, right? Either way, you're also going to find the T helper cells are going to be stimulating the B cells. And then at this point, which Ig is involved here? E is going to be the big one, right? So IgE gets released here, and that can also cause the mast cells to, activating a mast cell causes it to degranulate, right? So it's going to degranulate, and then it releases what? Histamine is going to be one of the main mediators. There's going to be other things as well, things like prostaglandins, things like serotonin, but histamine is going to be one of the primary things for that. So you had to imagine, how would I treat that? Antihistamine, yeah, absolutely. So if a histamine is a problem, well, just block it, right? Give drugs that can do that. So anyway, so this can be mediated through T helper cells. It can be mediated through directly with the antigen binding up to the mast cell. Again, these are usually going to be kind of working in tandem to cause a very kind of immediate sort of response here, right? Again, just showing you how the allergen can come in contact with the B cell. That will then release IgE. They can directly cause the mast cells to degranulate, or you have the allergen directly bind to the mast cell itself to cause degranulation, right? And again, if you had a very severe allergy in this case, what would you call that? Anaphylaxis, right? So what happens with anaphylaxis? Already mentioned you get hypotensive, right? What else can happen? Yeah, the airway is going to be a big problem, right? Because what happens to the airway? It starts to swell, right? So as you get that edema occurring there, because you're getting all that vasodilation, you're getting edema forming there, you can potentially close off the airway. So that's potential it could kill the patient essentially. And that's where if you ever hear a patient who's having an anaphylactic reaction and they're having pretty severe stridor, you know what a stridor is? Yeah, so you're having constriction of the airway, you're having this inspiratory wheezing, essentially what that is. That's a bad sign. It's a sign you need to get an airway stat, right? And so you need to get like an ET tube down or whatever it happens to be. But it's one of those things where the anaphylaxis is a very serious medical condition. Usually people who know they're at risk for anaphylaxis, they usually carry wet around with them. Yeah, they'll have like an EpiPen. So we'll see how that can be effective for us as well. Yeah, so anyway, so with things like epinephrine, how do you think that works for anaphylaxis? So it'll help with the lungs by hitting the beta-2 receptors. Absolutely, it's correct. That'll cause smooth muscle relaxation, right? That helps the lungs to open up. What does it do for elsewhere? constriction, right? The problem with histamine is causing a lot of vasodilation, so we can try to constrict things down, tries to help to limit that. So that's why we give epinephrine to try to help cause some vasoconstriction, also cause some smooth muscle relaxation, specifically with like the lungs. That's the main thing. That's the thing that's going to save their lives, essentially, right? And then we'll also get antihistamines to kind of deal with that histamines being released as well. And then also to tamp down that immune response, what can I give them? Steroids, yeah. So you're going to get basically them steroids to try to supplement what their adrenal glands are going to be releasing on their own. So again, that won't be quizzed on the test specifically. Just know that if the histamine's a problem, I can give something like antihistamine, right? So again, this is usually what you're going to see with an immediate sort of hypersensitivity. Delayed hypersensitivity is going to be a little bit different. This is something that usually takes longer to manifest, say 24, 72 hours after exposure. And you're going to find here that mainly the problem is the lymphokines being secreted, not really histamine. So in these cases, do you think histamine would be very useful? Not really, right? So you can take an antihistamine. In some cases here would be things like contact dermatitis or like poison oak or ivy, because this is more of a delayed sort of response, and really histamine isn't the mediator here, so those other lymphokines. You're going to find that really the histamine blockers are not going to be useful here. Well, what could I do instead? To suppress the immune system, like still give steroids. Yeah, so steroids would be a good option here to help deal with this inflammation. So again, looking between the immediate versus the delayed, you can see that immediate is going to be within several minutes. So again, when someone like has exposure to something like peanuts and they're allergic, they know about it pretty quick for the most part, right? Versus the delayed reaction should be a couple days. We're going to find the B cells are going to be more involved here with immediate reactions because again, this is IgE mediated, right? You think IgG and IgM are going to be better for what? It's going to be better for like fighting off viruses and bacteria and things like that, but IgE is mainly going to be for allergies here, right? Versus with the delay, it's going to be more cell mediated because due to the T cells being involved here. Again, most kind of common allergic reactions you're thinking of are typically going to be more this immediate sort of hypersensitivity here. And when looking at therapy, antihistamines are really good because we're releasing a lot of histamine. These adrenergic drugs, when I say adrenergic, what does that sound like? Sounds like adrenaline. So you think adrenaline, which is another name for epinephrine. Yeah, so epinephrine is another name for that. It's actually adrenaline. So you think adrenaline rush, like you think of being released as part of the sympathetic nervous system. I give epinephrine. That's basically going to be able to treat that because of all the vasoconstriction. You'd also give corticosteroids for this in some cases, but the delayed reaction, main treatment there is going to be giving something to help supplement the cortisol your body would be producing anyway, right? Make sense? Okay. So that concludes our immune lecture here. Any questions? Doing great on ending like right on time almost. Fantastic. All right, let's break for lunch, come back, and then start with farm.